Good morning to all. Topic of today's lecture is antisocial personality disorder. What is personality disorder? Before that, we have to understand what is personality. So, by definition, personality is any person's collection of interrelated behavioral, cognitive, and emotional patterns that comprise a person's unique adjustment to life. So, this is collection of behavioral, cognitive, and emotional patterns which constitutes the personality of a person. These interrelated patterns are relatively stable but can change over a long period of time. Now, what is personality disorder? When the personality of a person converts into disorder, it's a class of mental disorder which is defined as an enduring pattern of inner experience and behavior. Enduring means long-lasting pattern of inner experience and behavior that deviates markedly from expectations of individuals' culture. The behavior is deviated from the expected behavior of that for that culture and is pervasive and inflexible, which remains for longer period of time, and the personality traits which are deviation in case of personality disorder are inflexible. This disorder has often onset in early childhood or adolescence and is stable over time and leads to distress or impairment in life of the person. So there are three types of clusters of personality disorders: cluster A, B, and C, which is classified as per the common traits of these clusters. For example, for odd and eccentric traits, there is paranoid personality disorder, schizoid, and schizotypal. In cluster B, there is antisocial personality disorder, borderline, histrionic, and narcissistic. The common theme is dramatic, emotional, or erratic behavior. In cluster C, there is avoidant personality disorder, dependent, and obsessive compulsive personality disorder, which has common trait as anxiety and fearfulness. So we will discuss about antisocial personality disorder only because this is the syllabus of your curriculum. So what is antisocial personality disorder? Is characterized by pattern of antisocial behavior that begin before age of 15 usually. These behaviors violate the rights of others, and the individuals with this disorder display no evidence of guilt feeling at having done so. Whatever they have done, they don't have guilt feeling regarding this behavior. Substance abuse is not uncommon, it is common in antisocial personality disorder. I will call as ASPD instead of full antisocial personality disorder. Often the person with ASPD labeled as sociopath or psychopath in the lay literature. Lay literature means literature of common man. Regarding the etiology, there are various theories, the biological theories and psychological theories, in which one is temperament. In the childhood period, the person with ASPD displayed temper tantrums from infancy and would become furious when awaiting a bottle or a diaper change. They develop a bullying attitude towards other children in class or school. Parents report that they are undaunted by punishment. They do not bother about punishment because of their behavior and generally quite unmanageable. They are daring, foolhardy, and unaffected by pain. Theories of family dynamics. The family dynamics says that there are frequent chaotic home environment during the childhood. Parental deprivation during the first 5 years of life appears to be critical predisposing factor for ASPD. Separation due to parental delinquency is also a psychological cause, and inconsistent impulsive parents, and not the loss of consistent parent is environmentally most damaging to the development of antisocial personality disorder. The study shows that they have been severely physically abused in their childhood. The abuse contributes to development of ASPD in several ways. Several ways, like it provides a model for behavior. They see their parents, the behavior of their parents, and they acquire those behavior as a model. Secondly, these violence may result in injury to child's CNS, the brain, which thereby impairing a child's ability to function appropriately. And third one is engenders rage in the victimized child, which is then displays onto others in the environment. So the violence or the abuse which has happened to the child, they displays onto others their inner aggression. In theories of family dynamics, the following circumstances may influential in predisposing the disorder. For example, absence of parental discipline, extreme poverty, removal from home, growing up without parental figure of both genders, erratic and inconsistent method of discipline, being rescued each time they are in trouble, and maternal deprivation. So, what are the symptomatology and how the person with ASPD may present in the clinics? They may have various symptoms like extremely low self-esteem, inability to sustain satisfactory job performance, frequent job changes may be the presentation because of their antisocial behavior, inability to function as responsible parent, failure to follow social and legal norms, and repeated performance of antisocial acts that are ground for arrest. Whether arrest may occur or not, the behavior is sufficient to grounds for arrest. Inability to develop satisfactory, enduring, intimate relationship with sexual partner, aggressive behavior, repetitive physical fights, spouse or child abuse may also present. Extreme impulsivity. Impulsivity means acting without thinking of the consequence of behavior. Repeated lying for personal benefit. Reckless driving, driving while intoxicated. Inability to learn from punishment. For their behavior, they have lack of guilt or remorse. Difficulty with interpersonal relationships, social extroversions, repeated failure to honor financial obligations. This is the diagnostic criteria for antisocial personality disorder, which is known as dissocial personality disorder in ICD-10. The criteria A is callous unconcern for feeling of others, gross and persistent attitude of irresponsibility and disregard for social norms, rules, and obligations, incapacity to maintain enduring relationships, though having no difficulty in establishing them. They are very fast in making the relationship, but they cannot sustain that relationship. Very low tolerance to frustration and low threshold for discharge of aggression, including violence. Incapacity to experience guilt or to profit from experience, particularly punishment. Marked proneness to blame others or to offer plausible rationalization for the behavior that has brought the patient into conflict with society. They have a blaming tendencies. So certain behavior of ASPD is very difficult to uh, deal with. So the specific behavior of ASPD, which can be dealt with the skill and experience, will be discussed. The first one is risk for other, which is directed violence, the tendency to become violent. So one can convey an accepting attitude towards the patient. So therapist should accept the patient, so remain neutral and doesn't have any kind of rage towards that. So by accepting, feeling of rejection are undoubtedly familiar to him or her. So rejection they have got always in their life because of their behavior. So acceptance is required for therapeutic purpose. Work on development of trust. Try to gain the trust. Be honest. Keep all the promises and convey the message to the patient that it is not him or her, but the behavior that is unacceptable. The person as such is acceptable, but their behavior is not. Maintain low level of stimuli in the patient's environment, like low lighting, few people, simple decor, low noise level, because stimulating environment can increase agitation and promote aggressive behavior. Remove all the dangerous objects from the patient's environment so that he or she cannot purposefully or inadvertently use them to inflict harm to self or others. Help the patient identify the true object of his or her hostility. So this is self-realization. Encourage patient to gradually verbalize hostile feeling. Verbalization of feeling in a non-threatening environment may help patient come to terms with unresolved issue. The person may have some kind of unresolved conflict, internal conflict, which may be resolved by verbalization. Explore the alternative ways of handling frustration, like large motor skills that channel hostile energy into socially acceptable behavior. Staff should maintain and convey a calm attitude towards the patient because anxiety is a contagious and can be transferred from staff to the patient. A calm attitude provides the patient with a feeling of safety and security. But have a sufficient staff available in case of the patient become hostile. Administer tranquilizing medication as ordered, and if it does not work, then mechanical restraint can be used. The second one is defensive coping. Defensive coping means the coping style of that person becomes uh, the defense of the person becomes which is not in aligned with the rule, regulation, and obligations of the socio-cultural environment of the person. So one can explain consequence of violation of the limits. Consequence must involve something of value of the patient, value to the patient. All staff must be consistent in enforcing these limits. Consequence should be administered in a matter of fact manner immediately following the infractions. As soon as the deviant behavior is shown, so such strategies can be applied to normalize the person. In defensive coping, do not attempt to convince patient to do the right things. Do not use the words you should or you should not. Instead, use you will be expected to do this or that. The ideal would be for the patient to eventually internalize the societal norms, and this should be in step-by-step manner. Like, for example, either or approach can be applied. Either you do this or don't this, or this will occur because of this behavior. Explanation must be concise, concrete, and clear with little or no capacity for misinterpretation. Explanation must be clear cut. Provide positive feedback or reward for acceptable behavior. If the patient shows the acceptable behavior, one can give reward or feedback to such a required behavior. In an attempt to assist the patient to delay gratification, begin to increase the length of time requirement for acceptable behavior. For example, 2 hours of acceptable behavior may be exchanged for a phone call, 4 hours of behavior for a 2 hours of television, 1 day of acceptable behavior for recreational therapy, 5 days of behavior for a weekend pass. So this is sort of a setup which is kind of indoor setup. This is not for OPD setups. Now help the patient gain insight into his or her own behavior, and often these individuals rationalize to such an extent that they deny that their behavior is inappropriate. They find themselves always true. So try to put insight into their unwanted behavior. Talk about the past behaviors with the patient. Discuss which behavior are acceptable by societal norms or which are not. Help the patient identify ways in which he or she has exploited others, and encourage the patient to explore how he would feel if the circumstances were reversed. Put the patient into the reverse situation and uh, try to look for the reaction. An attempt may be made to enlighten the patient to the sensitivity of others by promoting self-awareness. And in the whole session or situation, this should be kept in mind that the person is acceptable and their behavior is not. The outcome criteria for defensive coping should be: patient follows rules and regulation of the milieu environment. Patient is able to verbalize which of his or her behavior are not acceptable. Patient shows regard for the rights of others by delaying gratification of own desire when appropriate. Now come to the chronic low self-esteem. This is long-lasting negative self-evaluation, feelings about self or self-capabilities. So while dealing with chronic low self-esteem, one should ensure that goals which are made are realistic, that can be achieved. Success increases the self-esteem. Convey unconditional positive regard for the patient. Promote understanding of your acceptance of him as a worthwhile human being. Acceptance by others increase feeling of self-worth because they uh, get the rejection almost all of the time. Set limits on manipulative behavior. Identify the consequence for violation for those limits. So set the consequence for that unwanted behavior also. Minimize negative feedback to the patient. Enforce the limits and impose the consequence for violation in better of a manner at the time of the behavior is acted upon. Encourage independence in performance of personal responsibilities as well as decision making related to the patient's self-care. Help the patient increase level of self-awareness through critical examination of feeling, attitudes, and behavior, and discuss ways to effect change in these areas. The outcome should be: patient verbalize positive aspect about self, patient demonstrates the ability to make independent decisions, patient expresses some optimism and hope for future, patient sets realistic goal for self and demonstrates willingness for reaching them. They have impaired social interaction also. Social behavior should also be targeted in therapy. Develop therapeutic rapport with the patient. Establish trust by always being honest. Keep all promises. Convey acceptance of the person. Separate from unacceptable behavior, that it is not you but your behavior that is unacceptable. Offer to remain with the patient during initial interaction. Provide constructive criticism and positive reinforcement for efforts. Confront patient as soon as possible when interaction with others are manipulative or exploitative. Consistency in enforcing the consequence is essential if positive outcomes are to be achieved. Inconsistency creates confusion and encourages testing of limits. Act as a role model for patient through appropriate interaction with him and her and with others. Provide group situation for the patient. So outcome criteria will be patient willingly and appropriately participates in the group activities. Patient has satisfactorily established and maintained one interpersonal relationship with therapist or the caregiver without evidence of manipulation or exploitation. Patient demonstrates ability to interact appropriately with others, showing respect for self and others. Patient is able to verbalize reason for inability to form close interpersonal relationships in current and in the past. Now, regarding the deficient knowledge, for example, self-care activities to achieve and maintain optimal wellness, the overall wellness of the patient. Assess the patient's level of knowledge regarding positive self-care practices. Adequate database is necessary for development of effective teaching plan. Assess the patient's level of anxiety and readiness to learn. Determine the method of learning most appropriate for the patient. Be sure to consider level of education and development. Develop a teaching plan including measurable objects for the learner. Provide information regarding healthful strategies for activities of daily living as well as about harmful effects of substance abuse on the body. Include suggestion for community resources to assist patient when adaptability is impaired. Patient needs this information to promote effective health maintenance. Include significant others in learning activity if possible. Input from individuals who are directly involved in the potential change increase the likelihood of positive outcome. Implement the teaching plan at a time that facilitates and in place that is conducive to optimal learning. Learning is enhanced by an environment with few distractions. Begin with simple concepts and progress to more complex. Retention is increased if introductory material is easy to understand. Provide activities for the patient and significant others in which to actively participate during the learning exercise. Active participation increases the retention. So outcome for this will be patient is able to verbalize information regarding the positive self-care practices. Patient is able to verbalize available community resources for obtaining knowledge and help with deficits related to the healthcare. So regarding the antisocial personality disorder, it requires multifaceted approach that encompasses empathy, patience, and a deep understanding of individuals' experience. Building a strong therapeutic alliance is crucial as it fosters trust and collaboration between the therapist and the patient. It is crucial to approach individual with its ASPD with a balance of empathy and firmness, recognizing the potential for change while maintaining clear boundaries. By promoting awareness, evidence practice, and understanding, we can contribute to reducing the stigma associated with these disorders and support individuals on their journey towards recovery. Thank you.